Good morning, everyone. I'm Dr. Yüsra Ağaoğlu from Istanbul Faculty of Medicine. Today, I'll present a rare and challenging case from TB endemic region in Turkey. And by the way, the patient has consented about this presentation and the reporting. Our story begins in 2019 with a 58-year-old woman from Elazığ, a region where tuberculosis remains endemic. And she had multiple TB risk factors, such as livestock exposure, unpasteurized dairy products, and a family history of TB. And she came in with severe back pain, and her imaging showed large, calcified, invasive mass, not just in the spine, but also spreading the liver, kidney, adrenal glands, and even the major vessels. And it looked serious and widespread, and the differential was broad. Infection, tumor, or both. And because of L3, L4 vertebral destruction, a spinal instrumentation and a biopsy were made, and histopathology showed necrotizing granulomatous inflammation. And this is a finding that, in our setting, almost reflexively means tuberculosis. And given our background, spinal TB seemed likely, and she was treated with anti-TB therapy for 15 months. And over the next years, she had mild pain relief, but never fully, and she still managed her daily life, and the treatment was considered as successful. 5 years later, in 2024, she came back to our clinic and with new and worrying symptoms, back pain again, but this time with urinary incontinence, gait issues, and imbalance. And repeat imaging showed the destruction of L3, L4 vertebra, and the mass progression. And she now had Cauda-Equina syndrome and a surgical emergency, and we realized that we had to rethink everything. And there was no obvious reason for treatment failure, such as non-compliance or malabsorption, and we suspected the multi-drug resistant tuberculosis and started the 5-drug regimen. And we thought that she could have a genetic vulnerability to mycobacterial infection, and we brought these thoughts in a multidisciplinary team. And together we decided on an urgent surgery, both to relieve spinal pressure and get a better tissue for the diagnosis. And we had some challenges. The mass was not confined to the spine. It extended to the liver, right adrenal gland, right kidney. And despite multiple biopsy attempts from these structures, a definitive diagnosis remained elusive, and her spine was still infected despite the previous treatment. And most striking, the mass was acting too aggressive for tuberculosis, especially with the liver involvement. But in Turkey, we have a saying that TB is the great imitator, but maybe this time something else was mimicking TB. And here is the paradox. The imaging looked catastrophic, but the patient was quite stable for years. Extensive invasion, vertebral destruction, even the vessel compression. And this mismatch between the radiological aggressiveness and normal symptoms forced us to take a step back and began asking, could this really be TB or something else? Are we missing something else entirely? So our focus shifted. And we started to consider a broader differential, and from slow-growing tumors to rare infections that can cause granulomatous inflammation. And TB was no longer the only suspect. And at this point, we needed something we could study truly study in depth, and that's what we finally got during the next operation. And the surgery was performed urgently. Spinal decompression and rod revision were made, and we sent comprehensive biopsy specimen for both microbiological and histopathological analysis, and the cultures and PCR for Mycobacterium tuberculosis came back negative again. But the real turning point came from the histopathology. PA and GROCO stains were positive, but the EZN was negative. And we saw laminated peaked structures consistent with the parasitic cuticle, and finally we had the real diagnosis. And imaging lacked cysts, which ruled out Echinococcus granulosus. Instead, the infiltrative tumor-like pattern pointed us to Echinococcus multilocularis. And anti-TB therapy was stopped, and albendazole was started. And finally, we had the real diagnosis. And with a confirmed diagnosis, we moved to the second stage, a radical abdominal surgery. We resected all the infected tissues, and despite the high complexity, she recovered well. And this phase was not just about removing the infected tissue, it was also about restoring the anatomical integrity and preventing the future spread. And the third and final stage of the surgery was aimed to stabilize the spine, and we performed L3, L4 corpectomy and placed the expandable cage to support the alignment. And she recovered well and continued albendazole and continuing her physical rehabilitation program and her daily life activities with minor limitation. And this case has some take-home messages, especially for clinicians like us in TB endemic areas. Echinococcus multilocularis can closely mimic tuberculosis or cancer when it forms infiltrative lesions, and necrotizing granulomas don't always mean tuberculosis. And histopathological stains like PA and GROCO, along with the serology, are crucial in identifying rare parasitic infections. And finally, reaching the right diagnosis requires true multidisciplinary collaboration, and without that teamwork, she might have stayed in the wrong path for years. Thank you.
Thank you very much. So, time for comments and questions.
Please confirm, at no stage have you grew any mycobacteria, and chemistry test or immune tests were also negative. It
They
was
were all
clinical
negative.
suspicion.
Yeah, clinical suspicion. She had family history and in an endemic area, and the necrotizing granulomatous inflammation almost always mean tuberculosis in our region.
Right.
Hi, thank you for an excellent presentation. I'm from Salome Pileo from Argentina. That's also an endemic tuberculosis region. And I think it's a fantastic reminder what you bring here, that tuberculosis scars are often reinfected by fungus, by parasites, and we shouldn't always think it's tuberculosis that comes back again after a correct treatment as you did in the first place. We should look for it, but we should also consider other terms. Thank you.
Thank you for your comment.
Is there in the history, did you find where did she get this echinococcus from?
She had dairy consumption, and she had animals in an Elazığ, Turkey.
Thank you for a nice case. Echinococcosis or hydatid cyst is common in that region, I think Iraq, and how often or how it is common in Turkey yet?
Echinococcus multilocularis,
Yeah.
you mean, right? Very rare. This is my third year residency, and this is the first time I saw Echinococcus multilocularis. We don't see much often. We usually see Echinococcus granulosus.
Any other questions or comments?